Hi, everybody. Welcome back to Voices of Verse Therapy. I'm Adam, one of the founders of Verse, and I'm excited to introduce Christine Corl. She's an experienced SLP working with us with over 19 years in the field. She specializes in pediatric feeding as well as swallowing disorders, early childhood development, and she's worked with clients of all ages in hospital as well as clinic settings. She's here to share her expertise and insights into the evolving world of teletherapy. And Christine, I want to say thank you so much for joining us.
Thank you so much for having me. I'm pretty stoked to be here, actually.
Awesome. So let's start with your journey. You've had such a diverse career working in hospitals, clinics, and now you work with us in a more like telehealth oriented setting. What inspired you to specialize in pediatric feeding and swallowing throughout that? And how has your career evolved over the years?
It's actually kind of an interesting journey because the way that I was even introduced to speech therapy was when I was a sophomore in high school and I started babysitting for a boy who is born deaf. And so I was introduced to sign language. And he got a cochlear implant, and I learned sign language with his family. And I was like, this is like a beautiful language. This is an amazing thing to work with these types of kids. Like, this is what I want to do. And so I went to college. Like, I looked at universities specific that had speech pathology, like, went in as an undergrad, declared, this is what I'm going to do. And then I, even for grad school, was still like, I'm going to work with deaf and hard of hearing. And so I went to Gallaudet University in DC, which is the only deaf and hard of hearing university in the world. And so all like, well, 80% of the undergraduate population is deaf. And so while I was there, you have to like within your curriculum, you have to do clinicals, right? And they're like, you have to do some in schools, some in hospitals. And I never wanted to go in hospitals. Hospitals were something that kind of like grossed me out. Like I was like, I'll go through it. We'll make this work. But I know what I'm going to want to do. And as soon as I stepped into a hospital, I was like, wow, there's like this whole medical component to what we do that is just fascinating. And I had to work, or not had to work, but I did a clinical rotation at the time it was called the Hospital for Sick Children in DC, which is a terrible name that has now changed. But yeah, that was when I was first introduced to pediatric feeding and swallowing. And from the NICU on out to like the cardiac ICU to all these other kids that were dealing with swallowing and feeding issues. And it just kind of changed my trajectory completely. And I went into the medical side of things, and I still love sign language, and I still love working with, you know, like early language learners and young kids. And it's always helpful to have that. Yeah, that's kind of, it was like a bit of a right turn.
Wait, I did not know that. So you went to a majority deaf undergrad?
Not undergrad, graduate.
Graduate. Okay. Okay.
So the
Gotcha.
undergrad, so it's in Northeast DC, not too far from Howard, and it's a school that was founded for all deaf and hard of hearing individuals. And the undergrad population, I might be a little off on this, but 80% are deaf. And then in the graduate programs, like for speech pathologists, audiologists, interpreters, social workers, they're like 80 to 90% hearing. And so it like kind of flip flops. And so, yeah, so I lived on campus, and I would say like I traveled abroad and into Italy and lived over there in Europe for a while. And I would say that I probably had more culture shock living on that campus in DC because your life is, you're immersed in deaf culture and in a deaf environment. So our doorbells and were lights flashing, our alarms were like the bed vibrating. So it's a really interesting kind of world to go into. And, you're in the cafeteria and it's very quiet and everyone's signing. And so it was really a cool experience, for sure.
That's crazy. Yeah. I mean, that's one of the coolest things that I've heard since we started this pod, actually. I haven't met anybody who did that grad program. That's sweet. So, do you have
It's a
a
pretty
bunch of
like
like
niche program for sure. But sorry, I didn't mean to interrupt you.
No worries, no worries. Yeah, I mean, I was just wondering, like, do you still have a lot of friends from having done that? Did you do undergrad in DC as well? Were you kind of like around the same group, or did you get like fully immersed into the that community in grad school?
Yeah, undergrad was actually in Virginia.
Okay.
So not too far, but I went to James Madison in Virginia and then went up to Gallaudet in DC. And I mean, the people that you go through that kind of a program with, you're kind of like tight for life. So like the people, my grad school friends, I think there were only 12 of us in my graduating class for our program. So there's, one third to half the class are still very, very close. And then I actually, while I was there, I ran track in college. And so I actually helped to coach the track team, the undergrad team at the university there. So some of the people that were like in the athletic program still keep in touch with me, and some of my old runners still keep in touch with me. So that was kind of a surreal experience because you would, give like instructions on how to, you know, go do a practice run or what your intervals were going to be. And if they didn't get it, it's not like you can yell and be like, hey, no, like you had to like run across the field and be like, whoa, 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 stop, stop, stop. Like, and kind of reset the whole thing. So it was an interesting experience for sure.
Seriously, yeah. What would you say were like the biggest differences that you noticed with them doing track versus like your experience outside of that? Like, obviously, you don't have like the gun going off and all of that. So, like, what were the things that you really noticed?
So like, yeah, that, like, I mean, like I used to do with the starts. So I would go position myself under the guy with the gun and do hand signals to help with the starts, depending on how far the kids were from the starting gun. So that was probably one of the biggest things. Funny story was I was actually in the weight room one afternoon, and like there were football players in there, there was a track team in there, and all of a sudden these two football players kind of like start to get into it, right? And all of a sudden I'm like, oh gosh, I'm like, and I look around and I'm like the only authority kind of like figure in the room. Like the other coaches have left. I'm like, what am I gonna do with these two guys? And they're like getting kind of in each other's faces. And with sign language, like that's your language, right? So I just turned the lights off, and that like squashed the conversation. And that was the one thing that I was like, okay, now we can everyone calm down, reset, and leave the weight room.
Nice. I mean, perfect to be a future SLP, always able to think on your feet. Quick segue into what you're doing now. So, again, kind of a niche thing, but you have
Yeah.
this really cool feeding therapy practice, and a lot of people may not associate that type of therapy, or at least that type of speech therapy, with telehealth versus other
Mhm.
specialties. So, like, what populations or specific cases do you find are the best fit for feeding therapy in an online setting?
I think anything where a feeding plan has been deemed safe and is established, and you can potentially accomplish that through teletherapy with the evaluation. Sometimes you do need to have more instrumental information prior to implementing a plan, which in those situations you'll need to actually go physically into a hospital or into a clinic. But once you have a set plan, I really think that telehealth can be honestly like a really great option for feeding therapy. And mainly because one of the biggest things is you're in the home environment already. And feeding is so much related to what your routines are at home, what you're eating at home, like how your family is responding to what you're doing at home. And so I think that was one of the biggest things when I worked in a clinic that I would often say to parents is, I am the therapist one day a week for 60 minutes or 30 minutes or whatever it was. You guys have to be the therapist the rest of the time because it's such a routine. Like things have to look pretty much the same and only slightly different every time. And so it really helps when a telehealth situation to have the family all there and to look into their world and be like, oh, this is your setup. This is your seating position. These are the types of foods that you're going to be using to really best address the child adult, whomever you're working with.
What does that look like tactically? Like, is that a Zoom that you're opening up at the dinner table?
Essentially, yeah. I mean, I used to do like I would have breakfasts with kids and like the parents and I honestly would see so much more buy-in from parents because like obviously kids can't like do it all on their own. Whereas like living, not living, but working in clinics, they would sometimes bring their kids with a lunchbox and I would take them back into the room. They may come, they may not. And in this situation, they've got to be there and present and preparing the foods and like talking about everything from the utensils you're using to the size of the bites to what types of foods to be giving next and how to kind of reinforce all those things kind of go lend themselves pretty well. And then it might not be that we're like in a dinner table with all the family, but it could be, and it just gives them real time hands-on experience to be able to replicate it meal after meal after meal, which is something that I think sometimes gets missed when you're in a clinic setting just because it's a little bit artificial, right? It's not your kitchen. It's not your dining
Yeah,
room.
totally. Yeah, even beyond feeding, I think the specialties within speech that we see end up doing that they would do well in telehealth. A lot of it's just because the SLP is not going to be living with the family. So this like modality where they're practicing these things and they're getting coached and they're learning to do it themselves so that they can do it the other 23 hours of the day, it ends up working pretty well. It's just like a slightly different approach from you being as hands-on. So I think that's a decent segue to just learn about your perspective on telehealth. Like, what do you think makes it not just an alternative or something that people could resort to, but sometimes the best option for certain families?
Well, I think well, when I think of best option, I'm like, the best option is like getting to therapy. And
Yeah.
sometimes the biggest stumbling block is just getting to therapy. And with certain populations that we work with, it's really hard to get them out of the house and it's really hard to get them in a car and get them in a new environment. And that can actually be really, really stressful. And so sometimes that is just the most challenging piece of it. So being able to like get kids into therapy and then also the just the buy-in from the parents and the involvement in the parents is just something that you can't gloss over when you're in their house.
Yeah, totally. And I would say that you are in a pretty good environment for it from what we've seen. Places like Seattle, obviously up at you, and then California, there does seem to be a little bit more momentum behind doing more of this stuff virtually. I think it's because a lot of the families and like working base have done remote and they're getting a little bit more open to it. And also, those places just have such shortages. So if you can kind of cut out commute time and make it so there's more sessions that can be done because you're not spending so much time commuting, and it kind of increases the SLP supply, which helps people just kind of like skip the wait list.
Totally. I mean,
So
there's just so many variables because it's like other kids in the family that are sick. It's traffic. It's the weather. I mean, there's like countless reasons why people don't make it through the door for therapy. So this just kind of like eliminates so many of them.
yeah,
Granted, I
absolutely.
was without internet from the windstorm, so that was a little bit of a one-off, but 99% of the time it's going to be something. And the other thing is that there's so much flexibility in it that even if you miss a session, the ability for you to reschedule within the same week is a lot higher.
Yeah, totally. Could you give me like an example of maybe one of these tools or strategies that you recommend for families to use at home when you're kind of coaching them up on feeding? So ways that they can take what they've learned with you in the session and bring it at home, like we talked about.
Yeah, I think one of the biggest things, like maybe it's my generation, the generation before, who knows, but there's all this idea of like, you're going to eat what goes on the table. Like, I'm not making four
Yeah.
different meals. Like, this is what's in front of your plate. And for some kids, that's actually, not necessarily the worst way to go. But for some kids, like there is an actual physiologic reason why they are not eating what gets put in front of their plate. And I think sometimes what's really hard for families is they just want to eat. They want to make one meal. And I get it. Everybody's busy. We all just want to make things as streamlined as possible. But they'll have like the kid will eat, crackers, and that's all they eat. And then they'll be like, I don't know why they won't eat the fish that I put on. And like the jump from crackers to fish is like mind-blowingly astronomical. So one of the biggest things that we work on is what's called food chaining. And it's like taking very small incremental changes to what a child will actually eat and change it ever so slightly so that the jumps aren't so crazy and it's actually like feasible that they might try something new. And it's also just educating because there's so much to learn about, like everyone just takes eating for granted, but like we all eat. Every kid's going to eat. They're not going to let them die. That's not actually true. Like there are kids who eat to refuse to the point of needing feeding tubes or supplemental nutrition in different ways, so it's kind of an old adage. And that is all because of a bunch of other things that I could talk about forever. But it's really like talking to the family about, okay, like we need to take what they will eat and we're going to incrementally change it systematically, very, very, very small amounts. And just kind of switching how the parents think about what they're going to present to the kids and their expectations. And I think that's a lot of it. Like 50% of feeding therapy is working with the kid, and 50% of feeding therapy is often working with the parents. And just kind of shifting how you approach the child and the meals.
Yeah, I mean, I sometimes wish that I don't know if it was the science at the time when I was coming up, but what you're talking about, where it's like you just clean your plate, that may have been like something from the Depression or like my parents
Yeah,
were raised.
it
So that
was
passed.
totally.
Got you. Yeah, so I still like really struggle with that, and I wish there was a way. It worked great in terms of making me not a picky eater, but I wish that I didn't like pick up some of the habits that came with that because it made it a lot harder to kind of pace myself with eating as I became an adult. So I think it's like
Totally,
really cool.
because you feel the need. I'm part of the Clean Plate Club. You
Okay.
were rewarded for cleaning your plate. You were rewarded for eating more food. And I think that there is something inherently flawed with that, right? Because then you have this because the portions have grown since we were kids or since I was a kid,
Yeah.
and so now cleaning a plate is like a whole other like ball game, you know? So yeah, definitely there's so much around food and the culture of food that is really interesting and shapes I mean, there are still, you know, I still have friends who talk about like that they won't let their foods touch, that there's very specific things that they don't want to do. And a lot of it stemmed back to like when they were younger, their parents didn't want them to get dirty. Like you washed your hands every time. If something got on your lip, it was like cleaned off immediately. And so like things like that, they've, shown that, it's good for kids to get dirty from a sensory perspective. It's good to explore the food. And I mean, one of the things I think that parents and caregivers just don't know is like that there are so many steps to learning to eat. And, like there's the whole idea of like seeing it, touching it, smelling it, all these things that you want to do before the last thing that they do is put it in their mouth. I'll watch, parents sometimes like put a kid's hands down and be like, here, right into your mouth, and it's like we've totally not allowed the child to do like 3 of the 4 steps that need to take place before that's going to happen. And it's not that anybody is trying to do any sort of harm or anything like that to their child. It's education.
Yeah, absolutely. There's huge like social implications to being able to figure these things out. I know, at least for me, I was super fortunate to grow up in like a very I guess diverse multicultural friend group. So uh, having that muscle where I'm like, oh, I don't care, I'll try it, was like very
Yeah.
huge for being able to go to my friends' families' places for dinner and all of that. One thing that kind of stuck out to me though, when you're doing this like chain feeding approach, and maybe you have someone who isn't as open to fish and are working their way up to it, is there like a standard chain, or is it something that you kind of make based off of what you've seen with the client? Is there like a usual set of foods that we build up, or does it change from client to client?
It's a good question. No, I think what it is kind of is you map it out. So I'll ask a patient or a family, I'll say, what are the foods that the child is eating? And they'll be like, and I'm like, what do you want them to eat? And this will be like a very easy example, but say like, okay, the child eats applesauce, but they want them to just be able to take an apple and eat an apple. And like, so how do we get to there, you know? And it's just incremental steps. So it's like you're going to incrementally make that applesauce thicker. Like you're going to blend it, but every time it's going to get a little thicker, a little thicker, a little thicker. Then you're going to start baking apples and bake them and maybe smash them so that there's still some chunks. And then you're going to bake slices so that they can actually start to chew the slices. And then when you're baking them, you're going to systematically bake them less and less and less so that they start to get a little crunch to them. And then you're going to be able to cut the apple like into slices and just eat slices that are now like not cooked at all, that are raw. And then the last thing is going to be like, now we have an actual apple on that we could try and eat.
I
So it's
see.
like very slowly changing the properties of it. Or there'll be kids, for instance, that like, sometimes it's as specific as, they will only eat Rita tater tots, that the bag has to be cut open from the bottom and served on the blue plate, and there's just not a lot of flexibility in what they'll do. And that's the one thing that they'll eat again and again. And it's like, okay, well, we're going to have to start with like, get tater tots that aren't a Rita. And like, that's the first thing that we're going to start doing. It's like that small of a step to start taking them in a different direction.
I could definitely see that. Would you say that the families that you're working with are predominantly motivated to do this for health reasons? Like, are they trying to get their kids into more nutritious food, or is it more like a life experience thing where they want them to be able to try more things or be able to, interact in different social settings with different food on the table?
It
What's their
depends.
main?
It's all over the map. I mean, it could be kids who primarily only drink their calories. They're only on formula and they won't start to chew foods. And how do you get a kid who's all on, formula or milk, and we can't get them onto actual solid foods and making that happen? It could be somebody who is just really restricted to us like 10 foods, and you can't go out to dinner. You make, like meal times are really stressful because often it's not just that they're very limited. There's also like behaviors that are surrounding, so that if there is something new, it becomes an outburst and it stresses the family. And that is another key component, is like that everything around feeding is like a big reaction, and it's just stressful. So I think it's usually the stress of it. There can be certainly health concerns because a lot of fruits and vegetables are missed in this type of population and these types of kids. Like a lot of carbs, a lot of cheeses are good, but the other stuff is kind of hard to come by. Some of it can also be kids who are working on oral motor skills. So they haven't had to build the skills to be able to choose certain foods and progress up. So that's a whole other aspect of it as well. So I think that swallowing across all ages is such a social connecting piece that everyone wants it to be pleasant. Everyone wants to be able to engage in it. So people who are on tube feeds that want to get off of tube feeds, people that, are just living with kiddos that make it a little bit harder to do the day-to-day things that connect us all, that like give us joy. I think those things are some of the most motivating. I haven't seen a lot that are just like, I really want to beef up this child's protein, like that specific. Usually it's a bigger thing than that.
Yeah, totally. Okay, so I'm wondering a little bit about the different client bases that you've seen. So you have this more heavy focus on pediatric feeding right now, or that's where you built a ton of expertise, but you've gone through all these different settings. So I'm really curious, when you compare and contrast your pediatric versus the adult clients that you've had, like how do you adapt your techniques for the different age groups that you've worked with? And are there unique benefits to doing this telehealth first approach for one group versus the other?
I mean, the biggest difference between peds and adults is like with pediatrics, they often, not all the time, but often they
Mhm.
haven't had the skills. Like, so we're building skills that they never developed. Whereas with adults, they often had the skills, but they're now lost because of an accident, an injury, something that has happened to them. And so it's trying to regain what they what they had then lost, you know? So I mean, there are different approaches and there's different levels of motivation depending on in both clients. I think that telehealth is great for both because it, like we talked about earlier, it is in the home environment. So you're using the things that you have within your home all the time. I think also with some of these populations, especially on the adult side, that also, depending on why they have a swallowing issue, getting out of the house for them can be equally as hard. So transportation could be an issue. You know, Time of the day can be an issue depending. So I think in both situations, there's tons of benefits to it. The other piece that I was going to talk about was I'm going to lose it now. I just had it in my head. Shoot, it'll come to me. But I know what I was going to say. The biggest thing though is it's not like I think this may have been discussed in one of your other podcasts, but it's not a matter of like the age of a child or the age of an adult. It's where they are developmentally that
Mhm.
really is where we meet them. So like an example would be I worked with a patient, I think she was mid 40s, and she had Down syndrome and another form of MR or mental retardation. And and so like developmentally and cognitively, she was more probably at the age of like a maybe an 8-year-old or something. And the approach that she really liked was when I was working with her, she had a trach at the time. And so when we do swallowing screening with patients with trachs at this hospital, you had to color it blue. It's called the blue dye test because sometimes if they cough out anything, you'll get, if you suction them afterwards and you have blue, then it's going down the wrong way and we have an issue. Well, she loved that all of her food was blue. And she ate the best when her food was colored in different colors. So now we have an adult patient, but I would come in and we would color the food just because that was what she thought that was great. And so she would eat better, she would perform better, she would participate more if we changed the colors of the food. And that
Interesting.
developmentally was where she was.
So there's like a little bit of a chaining there where they like the food in a certain color, and then you kind of through that teach them that they just like the food in general, or they're open to the food in general, and then they can kind of fade into just eating the food without it being colored every time,
I
or how
think,
does
I
that?
mean, I think with her, it wasn't necessarily so much of a chaining because she would eat. I mean, she had been eating prior. She had an accident. Was eating all kinds of foods prior to her accident that landed her in the hospital. It was more that she was not necessarily very compliant. She wasn't a very compliant patient. And this was an inroad to work with her, to get her buy-in and to participate with the activity.
As you go through this, one thing that kind of like comes up in my head is there's so many things that could be causing someone's reluctancy to eat. Like
Mm-hmm.
on day one, the first time you meet any of these folks, like where do you even start? Is there a standardized evaluation to understand like everything that's going on, or do you kind of like do a screening and then pick specific evaluations? Like what does the initial investigation look like?
Yeah, I mean, yes and no. Yes, there is like kind of like it's not standardized. They're working to more towards, there are standardized assessments that are coming, but a lot of the swallowing assessments from my era growing up were like informal assessments, but you covered the same things essentially. And a lot of it is just like a real extensive like medical case history to kind of see like where did they come from. And like that's like a huge component to it is just the etiology of why we are in this place. And for kids, like for adults, it's sometimes easy, not easy, but it's, like they had a stroke or they had a car accident or something of this nature, and it impaired, they had an injury to their brain, and now swallowing has been affected because of it, because of the area in the brain that was injured. And, or, they had a breathing incident, or they had, and then they ended up on a ventilator and ended up with a trach. And these things can all impact your swallowing. Or they had cancer and they've had radiation and various surgeries that now change the anatomy of the swallow. So those are like very easy to pull, like, okay, they're not easy to treat necessarily, but they're easy to be like, okay, this is the situation, and caregivers can get behind that. I think what's hard is with kids, sometimes the etiology isn't as different. And so kids get labeled as they're just stubborn. They're lazy eaters. They're, like it becomes a character piece almost. And so it's kind of trying to pull out and be like, well, let's like dig a little bit more into the history and like what was, like, when was he born? What was his first, like, did they have reflux? Did he have ear infections? Was he a good sleeper? Did he snore? Like little pieces that you could start to kind of pick away of like, why are we in this now current situation?
Yeah, I
Because
mean, you.
with kids, there's usually like a physiological reason why things start, but then there's a big behavioral component that gets reinforced over and over again. And so, like, for instance, if maybe I had a scary event, it could just be like one time of choking, and then I'm gonna avoid solid. Like sometimes it's like that little, but it could then be like I've avoided solids and I get scared, so I scream every time it comes near me, and my parents respond to that and give me what I want. And now I'm not really, I don't even remember being afraid of solids anymore, but I know like that I get what I want if I continue to scream, and I haven't eaten solids ever now. So now that's not familiar to me, and that's a little nerve wracking. So it's like a behavioral piece that can be reinforced over and over, even if the physiological reason is no longer present.
Yeah, it's clear that you spent a lot of time in a hospital because that sounds like almost exactly how my wife's a nurse practitioner, like how she would approach things, and she's in pediatric neurology, or like some of our old clients in like a previous startup that we had were hospitals, and it's like similarly just a big investigation like that. I think it's kind of
Mm-hmm.
cool that you found a way to use those skills in a setting that you like more. So like kind of sounds like the hospital felt a little too sterile for you, or it wasn't like your favorite environment, but now you're still able to kind of go through people's medical history and how they're behaving and kind of see what's up. So it's sweet that you kind of built this work for yourself.
I mean, I actually still love the hospital. Like, I worked a ton in neonatal intensive care units and on pediatric floors, and I love the energy that comes from them. I love the group think and the medical people that you get to learn every day. And, I always say every day is a school day. If you're not learning, but I think that this is awesome because one, it offers a little bit more flexibility for me and my family. And it also gives me the ability to like get into people's homes. Before, as much as I did in the clinics, there was still this barrier to the carryover. Like, why are the kids able to do it here, but they can't do it home? The carryover just wasn't there. And so it's nice to get in there. And I think that it can be more successful.
Yeah, it's so true. Would you say that in the hospital setting, would you say it was somewhat difficult to close the loop with people, or for them to kind of like get you updated on how things are going 3 months later now that they've been doing it fully in the home, or how did that kind of look like?
Yeah, I mean, for a while, I was working in a NICU that didn't have a follow-up clinic. And that was really hard because we would send these babies that we were working with for, you know, months out into, to work with people like me now, and you would never hear how they did, what happened, there was no closing of the loop. So that was really, really hard. And I think that, as a unit, that, people suffer because they don't have that closed loop because you don't know how to be better when you don't know outcomes like that. So, so yeah, I think with other clinics, like sometimes we would lose people because of distance, because of accessibility, because of a number of reasons. So I know a lot of times with NICU follow-up, but most hospitals have a follow-up program, at least some way associated with them. And the NICU like follow-up show rating is actually quite low. And I think part of that is because you're trying to get out of your house with a little baby. Like a tiny little baby who may be medically complex. They could have oxygen, they could have tubes. I mean, so many different things. And so I think this is an awesome option for people, especially who live further away. I mean, Washington is a catch-all for Alaska, for Idaho, I mean, we had kids that would come in from all over the place and then they go back to these homes. And that would be one of the biggest challenges is scrambling to be like, okay, what hospital in insert any city, where would they be closest to be able to get services? So this really eliminates a lot of barriers.
Totally. I mean, even in Washington, like just Washington alone, it has like one of the most interesting population dynamics between rural and urban.
Yes,
You have there's there's probably like five really major areas across the state, and they're completely distributed. It's not
hmm,
like you were in Chicago, I'm in Chicago right now, and grew up around here. You have a cluster here, and then you have a small cluster in
well, I'm in
Champaign.
Seattle now. I used to be in Chicago.
I know. You moved to Seattle, but I'm just like, you're in obviously the major cluster, but then you have Spokane on the
Right.
complete opposite side, and
Yes,
then all throughout the state you have these different dots, and it's like you don't have great SLP supply in all of these spots. So Washington's just it's a really good example of a state for this sort of thing, I would say,
it is. And I would even argue like Oregon's coastline can be tough
for sure.
because
Yeah,
most things are more inland and people go back out to the coast and there just aren't the same level of services there. And Eastern
absolutely.
Oregon at times too.
Yeah, totally, totally. I think we see, certain states where so much of the population is just in one urban like dot. Or if you go to the East Coast, like everything, you could basically like drive to most of the major cities, or there's only
Yes,
one major city in like a given state. But on the West Coast, it gets really interesting. So I think that could be a decent segue into just like your life outside of work, since we've been talking about flexibility in your move, right? So you were in Chicago for a while, went out to Washington. We chatted about this before, but you've kind of prioritized like getting out a little bit more. Obviously, Chicago is this like super social indoor food and drink type of culture. Washington can be a
yes.
little bit different. Here you enjoy your time like traveling and exploring the PNW with your daughter. So how do you balance such a demanding career with family life? And what are some of your favorite ways to recharge? Obviously, you're on a call with me right now, like 7 p.m. your time, so I
I
appreciate that.
know. For sure. Well, hey, it's even later for you. Well, I have to be honest, like my daughter's 13 months old, so I haven't really mastered it. Pre her, I was always a traveler. I was always like work hard, play hard kind of thing. And now it's more like find those times that we can get out. And she's like in my hiking pack a couple days a week, and we are just out, even if it's like for a 3 mile walk, hike, whatever, we'll get out there. And so I think that's like one of the biggest things. And one of the things that recharges me totally is just there's a park not too far from where I live, Lincoln Park, and it's like got these huge towering evergreens, and you walk on a plateau and then you go down a bluff and you're right along like the Puget Sound. And so like I'm carrying my daughter and I'm like, oh, look at the seal. Like look at sometimes we see we haven't yet with her, but I've seen orcas out there. You see, porpoises. And so just being able to get next to the water and see the mountains in the background, it's like, okay, this is good. And I mean, and hopefully as she gets older, we'll be, back off to Whistler skiing like I used to and, traveling around. But she's been on a ferry and get out as much as we can to just recharge ourselves.
Yes,
And
yeah. I
honestly,
mean,
like I was gonna say, and honestly, like I get so much energy also out of my patients. Like when you're working with patients and like, I mean, every speech therapist can talk like this because you become like, sometimes you become like part of the family and you're cheering for those kids the same way the parents are cheering for those kids, you're cheering for the family the same way. So, it's different. And even like working from home is different because I'm not having to like, sometimes like the commute was the worst part of the work. You know what I mean? Like that would be the thing that would drive me nuts more than anything. But getting everything like you can with your patients is to me, that's awesome.
yeah, totally. I mean, I harp on this a lot, but the one way that we try to do things a little bit differently, or like the gap that we're trying to hit with verse, is if we can have multiple SLPs in the state and, some of them are doing it as the side hustle, and we have like specialists that can hit every major specialty, then we can have a referral network where you are mainly just seeing like pediatric feeding folks, and you're not getting stuffed with like all of these different types of clients where there's like all this different context switching going on and like maybe not the best possible fit. Because one of the things that we've been kind of seeing is that a lot of folks with their day job, they just get these huge caseloads kind of shoved to them, and it may not be the exact types of folks that they're best at seeing. And I think that
Right.
that's just been like such a big thing to contribute to burnout. So for us, we're like, hey, let's see if we can work with more people, but it's more people kind of giving us less of their full time. But by
Hmm.
doing that, you kind of, as an SLP, only get sent the clients that are matched for you. So hopefully you
Yep.
end up being happy, and then that makes their therapy experience like that much better.
Yeah. Yeah, for sure. And I know we've like kind of deep dived into the whole feeding. I mean, I still love doing early childhood language, articulation, those types of things are still awesome. And even in the adult side, rehabbing the swallow and language is also fun. But yeah, I would say my passion is for sure the little ones.
Yeah, totally, totally, totally. I mean, and I think like even staying just within the same like age group is an awesome way to niche down that certain opportunities don't let you do, or just being like, hey, I only want to see more developmental cases rather than like cases, like just being
Hmm.
able to sort of set that. Yeah, I mean, last question I have for you is advice for families who might be considering like a telehealth approach for the first time. So, what advice would you give them to kind of make the most out of a virtual therapy experience, or if they're considering, virtual versus in person, like what would you tell them?
I think, honestly, I would say approach it like you were going into a clinic. Like set up with like the same level of questions, the same level of interest, the same level of buy-in, and see how it goes. And I think anything is worth a trial. And there are going to be certain kids and certain diagnoses and that are going to be have to be in person at times, And like I said, if there is truly like a swallowing concern and we can't get a plan that's safe like operating, you are going to have to go on and we're going to have to get more information, or you might have to go see another specialist. And that's okay. Like that's not a failed telehealth experience. Even if you were to come see me and face to face, I would might have to say, you're going to have to come back and get an x-ray swallow, or you're going to have to go back and get like a fiber optic endoscopic swallow or something, like, or you're going to have to go see ENT, so I think that there are going to be limitations whether we're in person or not. But I do think that there are so many more benefits to be had from the telehealth environment and just getting in your home.
Totally. Well, Christine, I mean, thank you so much for sharing your insights and expertise. Always a pleasure. Your work with feeding therapy and just everything with the kiddos is super inspiring. And I'm sure our listeners learn a lot from this type of conversation, whether they're SLPs themselves or just families that are looking for this kind of option. We're super grateful to have you on Voices of Verse and just on the team in general. And I can't wait to see the continued impact of your work.
Thank you so much for having me. This was awesome.
Sweet.